So good afternoon, everybody, and welcome, and thanks for joining us this afternoon. We have an interactive session planned for you, so we're going to put you all to work, and I'm hoping that you're going to find that fun and engaging. We're going to be discussing teaching diagnostic error prevention to medical students and residents. I'm Michelle Daniel. I'm the Assistant Dean of Curriculum at the University of Michigan, and I'm joined today by several of my colleagues who I'm going to have quickly introduce themselves.
I'm Dan Mayer, retired from Albany Medical Center.
Go ahead and stand, guys.
Yeah. Sorabh Khandelwal, the PD at Ohio State University.
Munzer, I'm an assistant program director and medical education fellow at Michigan.
I'm an intern at Ohio State.
Chris O'Cole, faculty at University of Michigan.
Chris. Yep.
My name's Chris Mayer. I'm the pediatrics program director at Brad.
Great, so let's get started. So by the end of this session, you should be able to really recognize how the use of illness scripts, heuristics, and pattern recognition can lead to bias, identify common types of bias in the emergency department, and we want you to also be able to develop a common vocabulary to talk about them. And then we want to teach you how to apply cognitive forcing or debiasing strategies to improve diagnostic reasoning when you're teaching cases. So we're going to begin with about a 15-minute overview of cognitive processes and debiasing, and then you're going to spend the bulk of the session working in small groups on a case, and then we're going to have a wrap-up with a report out of key lessons learned. So I want you to just take a moment to absorb this number, because it's a number that I find pretty disturbing. So the emergency department is really a very high-risk environment where this need for speed combined with conditions of uncertainty can really lead to unacceptably high diagnostic failure rates. Multitasking, frequent interruptions, they can cause us to lose track of the diagnostic process that we're involved in. And overcrowding and boarding patients can sort of stress us and push us to be moving faster, not allowing us to process adequately. And then the sheer workplace and chaos of the emergency department is just, it's filled with distractions. And so all of these things can lead to what is known as inattentional blindness. How many of you have ever seen, there's like a radiology image and it has a little gorilla in it, and they've shown it to hundreds of radiologists and they never see the gorilla. So that's really what inattentional blindness is, and it means that an event can happen right in front of you and you just don't see it because you're not paying attention to it. So two recent developments have really significantly impacted the way we look at diagnostic failures in emergency medicine. And the first is the development of the patient safety movement. And the second really is the incorporation of a cognitive science approach to decision making in medicine. So improving patient safety really requires a dedicated focus on improving diagnostic errors. And improving diagnostic errors requires us to understand how doctors think, which is based on something called dual processing theory. So what do you all see here? So I'm hearing STEMI. So you thought STEMI because you saw these ST elevations in 2-3 in AVF and V3 through 6. But what if I told you that this patient was a 34-year-old man who had a negative stress test 2 years earlier, and about a week ago he had stabbed himself in the chest. And on initial evaluation, he was negative for any acute injuries, and he was actually doing fine upstairs in the psych ward until he developed chest pain. Then what might you see? I think a more careful analysis of this EKG shows you that there's some ST segment elevations that are a little bit more diffuse than maybe they first appeared. And he's also got some pretty prominent PR depressions in lead 2. And that's suggestive of pericarditis. And this patient not only had pericarditis, but he actually had pericardial tamponade from a lacerated coronary artery. And unfortunately, he died after the cardiologist who saw this EKG administered TPA. So when processing information quickly, experts operate largely in pattern recognition mode, and that process gets us to the correct answer about 85 to 90% of the time. But occasionally something just isn't quite right, and we need to slow down and take our time reasoning through what really happened in the case to get to the correct diagnosis. So how many of you are familiar with dual processing theory? Good. This is becoming a little bit more mainstream. So a few years ago, if I asked that question, very few hands would have gone up in the room. So dual processing theory states that clinical decision-making basically occurs through two primary information processing pathways. And pattern recognition is this fast, intuitive, heuristically driven, and it occurs really largely unconsciously, whereas analytic thinking is slow and deliberate, and it takes place under our conscious control. And when our brains are functioning optimally, experts think that we toggle back and forth between these two processes. And so thinking about what just happened in our EKG example, our initial fast pattern recognition said STEMI. But a slower, more deliberate analysis of that EKG identified PR depressions and more diffuse ST segment elevations that were consistent with pericarditis, which might have prompted us to look with an ultrasound before administering TPA. So some experts believe that pattern recognition is more prone to bias. But I think the reality is probably more complex. And empiric evidence actually suggests that both processing systems are probably equally prone to bias. But we're going to focus our discussion today on biases associated with pattern recognition because it's simply the mode we operate in most of the time. So if we target that mode, we're going to be likely to hit what we're doing 85 to 90% of the time. So the concept of debiasing is based on the idea that you might be capable of recognizing some stimuli to switch to a more analytic thinking mode in real time. And such stimuli to switch can include the complexity of the case that you're confronted with. It can be a sense that, gosh, there are some high-risk things going on in the environment. The tech just handed me the EKG, and the resident was trying to give me an oral presentation at the same time I was thinking about this. Or it could be this heightened awareness that there's some feelings or emotional, it's sort of like taking your temperature of how your gut feeling is about this patient. And when faced with such stimuli, debiasing strategies might be deliberately employed. And debiasing strategies are really designed to force practitioners out of pattern recognition mode into this analytic mode of thinking.
Okay, so we can pretty much divide the types of cognitive errors. Thank you. Let me guess, it's the big button. The side button. Oops. Anyway, we can pretty much divide them into three broad categories. First one is premature closure of the differential. Basically, we make a guess about what is likely to go on, and then we stick with that. The second is stereotyping, where we have some stereotype about the patient that leads us in the wrong direction. And the third is that we have incorrect prior probabilities of what's likely to go on. Of these three, premature closure of the differential is probably the most common cause of diagnostic error, the most common underlying pattern in diagnostic errors. And what happens with premature closure is you do the shooting from the hip. You say, hey, I know what this is because I've seen hundreds of patients with this before, and that's what it's got to be. And you keep going with that without stepping back and considering that there might be some other factor. How many of you remember this case? So this is about December of 2014, and the 1914 one's not as interesting. And a young African man, comes into the emergency department in Houston, Texas, complaining of feeling crummy. He's got a fever, he's aching all over, he's got a runny nose, his muscles are hurting, he's got a cough. And the ER doc diagnoses him as having influenza. After all, influenza's epidemic down there at that time, and sends him home. Well, it turned out at triage that they had found out that he recently had arrived from Liberia in West Africa, and that he had actually had some contact with people who had Ebola. It turned out he had Ebola, and he was not diagnosed. He wound up going home and died. Fortunately, none of the people who were exposed to him wound up getting Ebola and dying. But again, you could see this could have led to a major catastrophe. So this is an example where the premature closure sort of preceded the knowledge of the facts that he had been elsewhere where he might have been exposed to some other illness. Stereotyping is something we all do, and I think that we've all been unconsciously influenced by the way people look, the way people act, the things they tell us. Let's do a quick exercise, and I'm going to show you 4 pictures, and I want you all just to take out a pen and paper and write down your immediate reaction. Don't even think. Just write down your immediate reaction to the pictures. Just 4 or 5 seconds per picture. Don't give it away. So there's some reading on that one. So our initial impression can be because of what we call affective or visceral bias. And this is just an example of stereotyping. We look at the patient and we say, this is something good, bad, indifferent, whatever it happens to be, but we're making a judgment based on how the patient looks. Sometimes this works well and sometimes it doesn't. Let's take this one, for example. I look at this person and I have these warm feelings towards this child. She looks like one of my granddaughters. I say she looks like a tough cookie. She's trying to, whatever she's got, she's really working through it without suffering too much, without demonstrating that she's suffering too much. And so I have a lot of admiration for her. But more often, we have negative emotions that are associated with this. Here's a guy, he's just a wimp because he's got the man flu and he can't take it, right? Sorry, you guys, they gave it away. But here we have a drug seeker. That's obvious. Anybody asking for a drug that starts with D must be a drug seeker. And this is someone who we feel should just be put out of their misery. And on other hands, it's something that we probably have all found ourselves doing at some point in time. And usually what happens is when we see these patients, we have an unconscious thought that brings us back and says, wait a minute, no, I'm stereotyping this person, I'm being prejudicial about them, and I should go back and think more about what's really going on and put my prejudices aside. And this is something that happens frequently in the emergency department. Your resident will come and tell you, oh, he's a frequent flyer, right? We've all heard that. She's a drug seeker. That extremely anxious patient in bed 10. These are all descriptions where the resident is demonstrating that they have stereotyped this person. And whenever you have that kind of an emotional bias in play, you should step back and think, wait a minute, how is this affecting me? Is this going to affect the way I care for this patient? And what can I do to make it stop? Like I had to do when I was treating a Muslim patient on September 12th, 2001. These can be fairly subtle. Incorrect probability is basically the fact that we don't assign reasonable probabilities, and I'm not saying 91 versus 92%, I'm saying high versus low probability to diseases. There are 2 common errors that occur here. One's called the availability heuristics, and these are both thinking patterns and error patterns. The availability heuristic means that what we've recently thought about, what we've recently seen, is what comes to mind. What we recently heard a lecture on. So you see a patient who sort of fits that picture, and now we're putting the picture from the lecture into that patient's bed. The representativeness heuristic is where we think that the patient's symptoms represent the disease. They match what's called an illness script. Another way of saying that would be that we've recognized that this is a 100% match on the pattern that we expect for this disease. And we may be fine, we may be good with that, and it may be the right thing, but we have to also wonder if maybe there's something else about that presentation that makes it, or should make it, to be less likely to occur, to make that disease less likely to occur, or the opposite, make it more likely to occur. And we can use some Bayesian decision making, which I'm not getting into now, to talk about how we might hone that, how we might fine tune that with just simple tests like getting a better history, doing a better physical, a simple X-ray or ultrasound, a simple blood test, things that might easily then give us the correct diagnosis. Now, most of you have gotten a sheet, a laminated card, where we list about a dozen biases. They all have the different names, and it's not important that you remember the names of all the biases. Those of you who are interested in it, we have given you references that'll give you huge lists of biases, of different named biases. But I think just recognizing that you can categorize them all into these three categories. For instance, oops, what did I do? Is there a laser here? This one. Here we go. Visceral bias at the bottom is the stereotyping that we've been talking about. It's how the patient makes you feel. And what we're giving you these cards so you can use them both in the exercise now, but we want to encourage you to put them in your white coat or wherever you carry around, and use them when you're debriefing your learners, debriefing your residents or your mid-levels or students, and try and identify which biases might be active at the time, which biases might be important, and which biases you ought to be keeping away from. And that should be something that happens, well, in the training, in the teaching situation with every patient you see. You should have a brief diagnostic timeout where you say, hey, have I been victim to one of these biases, and is this something that I should be thinking about? All right, now what we're going to do, ooh, we're right on time too, good. So we're going to divide you up into, we're going to let you divide yourselves into groups. Unfortunately, the room isn't really conducive to little round tables. So we'll ask 4 or 5 people together, to work on cases. Most of you should have the cases. Those of you that just came in the back, lots of seats down front, or try and sit with someone who has one of the case packages. We've got 4 cases, and we'll have you each group do one different one. We want you to go through the case and think about what biases are occurring. When you read through the brief history and physical and the initial events of the patient's presentation, underline those comments, those parts of the history and physical that you think are important and that might have led to a correct diagnosis if there hadn't been some diagnostic error made because of one of these error patterns, either premature closure, stereotyping, or incorrect prior probabilities. And we've got a couple of other faculty who will walk around and we'll be glad to talk to you about it. And then after about 15 minutes, we want you to just report back, give a very brief summary of the case, like 3 sentences, and then just talk a little bit about the biases that you've seen, and then we'll have a discussion about that. Want to add anything, Michelle? Yep. Good to go?